With over 1 million members, we know what people can do when they come together. We are Rotary. We are people of action. Find out more at rotary.org/action.
Good afternoon. Welcome to a special live presentation of Rotary District 6150. We hope everyone is safe and healthy across Arkansas. My name is Hatton Weeks. I'm a member of the Rotary Club of Jonesboro. I'll be your host and moderator today. Thanks for joining us on either Facebook or YouTube. And at the end of today's presentation, we're going to be taking your questions. We need this to be interactive, so please ask questions. You can ask them in the chat window as the presentation goes along. We'll take them at the end of the presentation. And while you're there, please take a moment to like us on Facebook or subscribe to the YouTube channel, Rotary District 6150. Now I'd like to introduce our Rotary District 6150 District Governor. George is a member of the Rotary Club of Lawrence County. He's now retired, but spent a career leading hospitals and medical facilities across the district footprint. Today's virtual meeting is his idea as we look to stay connected and stay informed. Rotarians, please welcome 6150 District Governor George Fray. George?
Thanks, Hatton, and thanks for being with us today for this special Rotary District 6150 seminar. My name is George Fray, your district governor, and our presenter today is Dr. Jennifer Dillaha, state epidemiologist with the Arkansas Dept of Health. She is a fellow Rotarian and a member of the West Little Rock Club and was recently named Rotarian of the Year by that club. I want to pause and remind you of the virtual district conference that will be conducted on Saturday, June 27th. It will start at approximately 11 a.m. and will finish by 2 o'clock. We're excited for several reasons, one being that it will be a celebration, and second, it will present the opportunity for more Rotarians to attend the district conference than ever before without leaving their homes. Please make plans to join this important celebration. Dr. Dillaha, a Rotarian and a member of the West Little Rock Club, she became a Rotarian in April 2011 and has come to understand what Rotary means to her personally and professionally. And she is here to share with us an issue that she has become deeply involved in. Dr. Dillaha has worked at the Arkansas Dept of Health since 2001, where she has played several roles over the years. In March 2020, Dr. Dillaha was named the state epidemiologist for Arkansas. This in addition to her role as medical director for immunization since November of 2013 and the medical director for outbreak response since August of 2019. Her charge in the role of state epidemiologist is to provide leadership and guidance for addressing Arkansas's most pressing infectious diseases, including COVID-19. She is also charged with improving Arkansas's immunization rates, particularly among adults. She is uniquely prepared for that role as a physician with specialty training in internal medicine, subspecialty training in infectious diseases, and in geriatric medicine. Her topic today will be an update on the COVID-19 pandemic and what it means for Rotarians in Arkansas. Please join me in welcoming Dr. Jennifer Dillaha.
Well, good afternoon, everyone. I'm glad to be here with you today, and thank you for having me back to do an update. So, as you know, the pandemic has continued to progress around the world as well as in the United States. Worldwide, we have almost 9.5 million cases with well over 480,000 deaths. That's about a 5% death rate. So about 5% of the people are dying when they get COVID-19. In the U.S., we have over 2,336,000 deaths. 2,336,000 cases and over 121,000 deaths. That's also about a 5% death rate. In Arkansas, we have, as of yesterday, 17,375 cases with 240 deaths. Our death rate is lower than the national death rate. It's about 1.5%. I would like to talk a little bit about how the disease is spread and what it's like when you get the disease. So this disease we know is primarily spread by person to person. It's possible that it's spread from the environment, people touching things and getting the virus that way, but by and large, it's spread from person to person via respiratory droplets. That means that when people cough or sneeze, they give off droplets and they fall to the ground, or they get on a person, or they are inhaled by a person. But more and more, the evidence is showing that aerosolization of the virus also plays a role. And those are the particles or droplets that are much, much smaller than the kind that fall to the ground. They're generated when we cough. I'm sorry, not cough. They're generated when we talk, we laugh, or we sing. And these particles are small enough that they don't fall to the ground immediately. They stay in the air. They can get in some of the immediate environment and accumulate there. And those are the particles that when people breathe them in, they go deep into the lung and are much more likely to establish an infection. When people get their infections, there's this whole range of illness. People who don't really have symptoms at all, or such mild symptoms they don't recognize it, all the way to very severe illness, and people die from it. Most deaths seem to be related to severe respiratory failure. More and more, we're seeing that clotting, blood clotting, and some disorders along those lines contribute to death. It appears that the majority of cases could be asymptomatic. I've seen literature that shows 40 to 45% of the cases, people don't know they have it unless they get tested. They just don't have symptoms. In Italy, one study showed that 50 to 75% of the people tested positive did not have symptoms. So you see this range. 80 to 90% of the people have very mild symptoms or none at all, and 10 to 20% will have some sort of symptom. And oftentimes that's like difficulty breathing. It can be severe pneumonia. It can go on to cause what we call acute respiratory dysfunction syndrome. It's our acute respiratory distress syndrome, where the lungs just can't function. And then it can progress to multi-organ failure. We also see that occasionally people will have gastrointestinal disturbances with diarrhea, and the diarrhea can itself spread the virus. And so one of the things that's being looked at is to look at our samples from our sewer systems to see if we can detect it, kind of like we do polio around the world, to see if it could be circulating in the community and use that as an early warning sign. For those people who become severely ill, the course of disease is typically something like flu-like symptoms for, say, several days, 6 days, and that worsens till they just have overt shortness of breath, difficulty breathing for maybe 8 days, and then they end up in the hospital maybe for 10 days, and then they end up having to go on the ventilator, and then they die. So that's the extreme case. But unfortunately, this happens all too often. I wanted to talk a little bit about the duration of immunity. Well, first I'll back up a little bit and talk about treatments. So currently there are studies going on to see what works best to help people with this illness. There was studies that were well published, a lot in the press about hydroxychloroquine, and that appears not to be effective, and that the risk is greater than the benefit. So it's not recommended anymore, and the FDA removed its approval for that drug to be used for treating COVID-19. There's one drug called remdesivir, which looks like it's effective and it's very promising, and we have that available in Arkansas, so hospitals are able to use that for their patients. And more recently, a steroid treatment has been tried with a steroid called dexamethasone, and that seems to benefit people. So it's hopeful that, more and more we're showing that it's possible to treat the disease and at least shorten the course or make it more survivable. And then I'd also like to talk a little bit about vaccines, because vaccines are kind of what we're hoping for, because we do not have innate or established immunity in our populations. And if we could have a vaccine, that would make a big difference. There, around the world, are over 100 different vaccines under development, and there are several in the US. Right now, there are 2 that are being looked at that have progressed through the clinical studies that will hopefully complete the studies in the early fall. And so it's very possible that we could have a vaccine available in the United States before the end of the calendar year. This is very exciting. You may not know that, when a vaccine undergoes a study, the manufacturer will make doses of the vaccine enough for the study, but they don't make doses to sell until the study shows that the vaccine is effective. In the case of this pandemic, though, the manufacturers are going ahead and making hundreds of millions of doses so that if the vaccine is effective, doses can be immediately available. And you can imagine what a huge financial risk this is. But because of the severity of the pandemic and the illness that it has caused, there are financial backers, including the Bill and Melinda Gates Foundation, which are funding the manufacturing of the vaccine in advance of the completion of the studies. The studies are being done well. The safety will be well established before a vaccine is released, but you can imagine that this is a pretty big risk on the part of those who are investing in this effort. I'm feeling hopeful. I've read a little bit about the vaccines, and I think that it's going to be something that will make a difference. One of the things that I'm often asked about this illness, COVID-19, is, well, why don't we just let people get the illness, and if a lot of people get it, then we'll develop herd immunity. And then we won't have to worry so much about it circulating in our communities. Well, there's a couple of things I would like to point out. One is we don't know if we can develop herd immunity to COVID-19. We know that there are other viruses that cause the common cold that we do not develop herd immunity for, because our immunity for those viruses wane over time, and we can get those viruses again and get the common cold again from those viruses. So it's possible that we might not develop lasting immunity for the COVID-19 virus. We know people will develop some if they get over the illness, otherwise they wouldn't get over the illness. But we don't know the duration about how long that lasts. It could be weeks or months or a year or something like that. We don't know. So we cannot presume that if we let a lot of people get infected with the illness, then we would have herd immunity. The other thing that's important to think about is just what level of herd immunity would be protective even if we could develop it. So, for like measles, to develop herd immunity, you need about 95% of the population to be immune to keep it from circulating. It's so highly infectious. But let's say for COVID-19, if we could develop herd immunity, then let's say just 70% of the population would need to be immune. Well, in Arkansas, we have about 3,020,000 people. So 70% of the population would be 2,114,000 people about. If we were to develop that level of immunity, some people would die in that process. So if we have a 1.5% death rate like we have right now, that's 30,000 Arkansans that would die of COVID-19 on the way to us getting herd immunity, which I'm not sure we can achieve. If we have the 5% death rate like the rest of the country, then that's 105,700 deaths in Arkansas that would occur before we could have herd immunity. And as I said, I'm not sure we can get herd immunity. So if we can get a vaccine that would stimulate lasting immunity, then that would be of the greatest benefit to us. And so for that reason, I want to talk about what we can do in the meantime to prevent the spread of this illness. And you have heard me say it before. We need people to maintain a physical distance of 6 feet or more. If they're not able to do that, especially even if they are in an indoor environment, people should wear a cloth face covering. That's what people need to do to prevent themselves from spreading the virus to other people in case they have it and don't know it. I think that's really, really key. There's more and more illustrations and data that show that wearing a cloth face covering can make a tremendous difference in the spread of this disease in a community. And then the final thing I wanted to talk about was going to phase 2 in Arkansas. We have been seeing a surge of cases in our state. We've looked at the data to see if it's in those places where we lessened the restrictions. So we're not really seeing cases coming from restaurants or gyms or beauty parlors or barbershops, but we are seeing cases coming from churches. And it's so far been churches that have chosen not to follow the guidelines of social distancing and wearing cloth face coverings. So far, we haven't seen any church-related outbreak in those churches that are meeting right now, but follow the guidelines. And the guidelines are on the health department's website. So we strongly encourage churches and businesses and organizations that have person-to-person interaction to follow the guidelines so that we can reduce the spread in Arkansas. And I also want to say that there's a couple of good things on the horizon. The health department is coming close to completing testing of all nursing homes and assisted living facilities in Arkansas to see if there's any undetected cases of COVID-19 there. And then in those nursing homes where there's no cases, then guidelines have been put together to allow people to visit their loved ones again in nursing homes and assisted living. And I'm so excited about that because I've trained as a geriatrician and I know how critically important that is for families and our older adults to do well. So I'm excited. That's going to go in effect for July 1. So those locations that don't have cases can start having visitation if they follow the guidelines. And it's really important to follow the guidelines because you don't want to introduce COVID-19 back into a nursing home that has had it before, or to introduce it into one that hasn't had it at all. So I'm very excited about that. So I'm going to stop now and let people ask their questions.
All right, visiting with Dr. Jennifer Dillaha, fellow Rotarian and the state epidemiologist for the Arkansas Department of Health. She is our infectious disease specialist. We're taking your questions. If you're watching us on Facebook Live or on YouTube, ask a question in the chat window. We'll get to as many of them as we possibly can. You know, Dr. Dillaha, you were mentioning about how many asymptomatic cases that we're seeing here in Arkansas. How many more people do you think are walking around in the state of Arkansas who are asymptomatic and have not been tested?
You know, there have been some estimates of that, and I don't really have a good feel for how many that can be. But we know that, especially in communities where it's spreading, we have some hot spots in Arkansas, like Northwest Arkansas, Washington, Benton County, Sevier County, and some in the Arkansas River Valley, that those cases, of course, it's going to be more likely in those communities that people are walking around asymptomatic than in those communities where it's not spreading. So I encourage people to stay up to date, look at the health department's website of the counties about the number of cases and how they're growing. We're working to improve our website so people can have a better feel for what the dynamics are in their community. But I think it's important for people to know locally what's going on, even if we can't give a big estimate about how many cases are out there. We know it's more likely to be the case when there's spread in the community, and that spread has been documented.
Understood. Question coming in from Charlene Walker. Do you also think that the spread is because of the good weather and people going to the river and having large gatherings?
So I think part of the spread is can be attributed to people trying to go about their normal lives and being tired of the pandemic and doing things they did before the pandemic. I think the spread is less likely to occur when people are in an outdoor environment because you get that dilution effect, you know, the air coming in. But if you've got people riding together to get to the river in a closed vehicle, not wearing masks, or if you have people who are at social functions, even in the outdoor, you get enough people in the space, you can spread it to one another. So, and we have seen spread at funerals, weddings, parties, you know, these kinds of social functions where people just want to be together and they decide that they are tired of all of this social distancing and wearing the cloth face coverings, and they don't do it. And then guess what? It spreads.
Now they have it. You know, the death rate in the United States at 5%, and here in Arkansas, it's I think you said 1.5%. What's driving that in Arkansas? Why is our death rate apparently lower than what we see in across the country?
Well, that's a good question. You know, we've looked at to see, are we getting all the reports of deaths? And we know that there might be some we miss. I wouldn't think that what we miss would be any greater than any other state. So that doesn't really explain it in my mind. One of the things that I think we have done in Arkansas, you know, 70% of the deaths are in people who are 65 and older. And we've seen that in other states where you have a lot of deaths among the older folks when it goes into a nursing home. In Arkansas, we've been very aggressive. When there is a case in a nursing home, we go in and test everyone because we know that there's going to be people who are asymptomatic, and we test the residents and the employees. And we've been able to do a very good job of testing quickly so you know the results and you can separate people in one wing who have COVID-19, in the other wings they don't, or if they've been exposed. And we have a very good healthcare associated infection team, an HAI team that we call, who's done a fabulous job in our congregate living situations, nursing homes, correctional facilities, and other kinds of residential settings like our child, I forgot what we're called, human development centers that we have in Arkansas. So I think that has contributed to it, but it could be that people are being more cautious among older adults, and in rural areas, we haven't seen the kind of spread. What we're seeing are work sites and social gatherings that don't follow the guidelines, and it could be that maybe we're just not exposing the older adults.
Next question from Kathy Jones. So is our strategy to try to minimize COVID-19's effect on our healthcare system until a vaccine is available?
Yes. So what we really want to do is lower the burden on our health system. Initially, we stopped elective surgeries, and the hospitals developed capacity. And then we didn't have the initial surge of patients that we thought we were going to have. So we've resumed elective surgeries, but we are monitoring the number of beds. So the hospitals around the state report to the health department what is their bed capacity, how many beds are full, so how many beds are available. And we do that for regular hospital beds, we do it for ICU beds and ventilators. So what we want to do is, if we have a surge, to take steps, and all hospitals have a surge plan, and they work within their system. If they're part of a hospital system, they could have patients go to a different hospital, or they could cut back on the elective surgeries that they do. But we want to make sure that people who have other illnesses can get the care they need, but also have plenty of ability to take care of patients when they have COVID-19. So we're trying to lower that as much as we can to keep the hospitals from being overfull, and then allowing our clinics that have been doing remotely, that now starting to see patients, also protect them and their capacity to take care of patients of all types that may need care.
I have a one more health facility related question, then we're going to talk about masks after that, getting a lot of question on masks. But from Brian Riga, the president of the Rotary Club at Jonesboro, do you have any feelings or insight into long-term care facilities opening back up to visitors?
Yeah, so a long-term care facility, the residents themselves won't bring the COVID-19 virus in. It's going to be the workers or the visitors. And they are more likely to bring it into a long-term care facility if there's a spread in the community. So this is a situation where the nursing home or the long-term care facility, assisted living, won't be safe unless the community is safe. And we see this also in work sites. The community can't be safe if the work site is not safe. So we have these many facets of our communities that have to work together to keep each other safe. That is why I feel it's critically important for everyone to engage in social distancing and wear a cloth face covering whenever they're outside their homes, out in public. If you're alone out in the woods, that's different. I'm talking about when you're in public around other people. Even if you think you can keep social distancing, sometimes you can't. And it's just better to be on the safe side than to do things that are going to promote the spread, and wearing cloth face coverings will diminish that. So my hope is we can keep the nursing homes safe by keeping our communities safe.
And you are transitioning to masks, getting a lot of questions.
Okay.
Should we just wear them at outdoor events? Here's a question from Francine that I'm not sure that we can ask, and that is there a reason to just not mandate people to wear masks rather than just strongly recommend?
So the medical recommendation is to wear them. Mandating is a policy political decision. And if we mandate it and people don't wear the mask, it doesn't do you any good. If people wear the mask and we don't have to mandate, then that does good. So it's wearing the mask, and it's really a culture change, and a culture change is hard. And I do not, at this point in time, know what the best course of action is going to be for Arkansas. And I'm leaving that to the governor and to Dr. Smith about whether they want to push for a policy to do that. But we can have our own civic responsibility, and that's why I just implore the Rotarians around the state to be the change we want to be, and make sure their businesses are requiring masks. They have that option, and it's important for people to know that this is I guess you would say, a civic or a social expectation. But the mandates are a policy political decision that we will have to weigh carefully in Arkansas if there can be enough support for it. I do not, at this point in time, know the answer to that.
We are visiting with Dr. Jennifer Dillaha. She's the state epidemiologist for the Arkansas Department of Health, taking your questions on COVID-19. You can ask those in the chat window, either on Facebook or YouTube. Next question comes from Charles Harris. If you're 65 or older and healthy, are you still at a higher risk of death from COVID-19?
That would appear to be the case. You know, we know that people who, the older we get, the higher our risk. And we know that people who have chronic health conditions, and many older people do, but people with chronic health conditions of any age are at increased risk. So that's one reason that I think it becomes incumbent on the community to help us protect each other and the people who are most vulnerable, the older adults and those with chronic health conditions. And you know, in Arkansas, a lot of people have chronic health conditions.
Very good question. You know, a lot of people are looking back into the winter and spring and thinking, you know, I think I had it. So what are the chances that this novel coronavirus has been around Arkansas longer than, say, February or March?
So we actually thought that we had a case earlier as someone who passed away, and we actually were able to test specimens, and they didn't have it. So I'm thinking it probably didn't circulate in Arkansas before the first part of March. Of course, if people had it, they could probably still get it again. We don't know. So knowing you had it doesn't mean you're protected, and we can't say you have immunity for it. But there was a time in January, beginning of February, around those times, when we had a lot of respiratory illness in Arkansas. In fact, I even remember being sick at that time and talking to some of my colleagues who are primary care doctors about how heavily hit that their practices were with people who had these respiratory illnesses, and not really knowing what it was. Apparently it wasn't the flu, it was something else. And I do not think that those illnesses were COVID-19, because I think if they were, we would have seen a spike in hospitalizations, and we did not. So we couldn't have tested for COVID-19 back then, but I think we would have seen a change in the pattern of admissions to the hospital, and that was not noticed at that time.
You know, you mentioned you're seeing a lot of cases coming from church gatherings, from churches who are not practicing recommended CDC guidelines. Michelle asked a question here, Michelle Oglesby. Do you think our increase came from the protests that occurred, and I'm assuming the one from a few weeks ago? Yeah. That's coming from Michelle in Sherwood.
So we've been actually looking at that, and we do have people who were tested positive for COVID-19 and report that they have been to such a gathering, but we aren't seeing high numbers. So it's so we can't really say those individuals got it there. And that kind of makes sense because when we identify a case of COVID-19, we want that person to isolate so they don't transmit it anymore. And then we look for the close contacts, the people who would have been around that they were most likely to transmit the virus to. And that's people who would have been within 6 feet for more than 15 minutes. And many of these protests, that wasn't the dynamic. There were people out and about and lots of people, but they weren't all standing within 6 feet of each other for 15 minutes for that transmission to occur. So I'm thinking that the protests probably were not great spreaders of COVID-19, even though we do have some reports of people getting it and having been at a protest, but we can't say they really got it there. It's hard to know.
Last question I'll ask you, Dr. Dillaha is the state epidemiologist. With all that is going on with COVID-19 in the state, what's the one thing at night that keeps you up?
It's all my unanswered email. No, the one thing that really I spend a lot of time thinking about is how can we promote a culture change where people will wear cloth face coverings to protect their fellow members of the community. We tend to think that we're okay, it's not hurting me, I'm not sick, and not realize that the mask really protects other people. And that's a difficult culture change.
Dr. Jennifer Dillaha, the state epidemiologist for the Arkansas Department of Health. If you don't take anything else away from this conversation, it's three things. Wear a mask, wear a mask, and wear a mask.
Yes. Thank you.
Thank you very much, and always appreciate the conversation. And we will turn things back over to District Director George Fray. George?
On behalf of the members of District 6150 and myself, I would like to express our sincere appreciation to Dr. Dillaha, moderator Hatton Weeks, and producer Sam Hummelstein for sharing this vital information with us that has been very informative. It's eased our fears and helped us adapt to this new normal. We look forward to more updates. We look forward to seeing you Saturday morning at 11 o'clock for district conference. This concludes our program for today.